good afternoon to our members, councillors, and also good afternoon to all of our officers, and a particular welcome this afternoon to Stephen Bloomer. Welcome to the fray. I'm sure that you're going to enjoy we're quite harmless really, but obviously we're here to scrutinise, and so lots of questions will be coming everybody's way in a moment or two. But it would be very remiss of me not to pass to Councillor Maggie from the the Royal Borough of Kensington of Chelsea to officially welcome you as the host borough. Over to you, Councillor O'Maggie.
Yes, thank you, Councillor Collins. Yes, thank you, Councillor Collins, and welcome to the Royal Borough of Kensington, Chelsea, for this virtual meeting. I hope we will have a very good, engaging session, and that's it. So welcome. Hopefully, when this pandemic is over, we'll welcome you physically here. So let's have a good afternoon. Thank you, Councillor Collins.
Thank you. And may I also
Councillor Collins, over to you.
Thank you very much, Councillor Maggie. May I also extend a very warm welcome to everyone who may be tuning in via YouTube. You're most welcome to listen to the debates that will ensue in a few minutes when I've done the usual housekeeping. So my name is Councillor Melvin Collins. I represent Brentford Ward on the Council of London Borough of Hounslow, and I am the current chair of the Joint Health Overview and Scrutiny Committee for North West London. May I also welcome my councillor colleagues from the other boroughs, and also welcome all of the members of the NHS team who will be doing the presentations and answering our questions in a moment or three. So first of all, to ask whether there are any apologies for absence, please. I take that as a no. Thank you. So are there any declarations of interest from members around the table? So that's our councillor members.
Yes, Chair, I'm the lead governor of Central and Northwest London NHS Foundation Trust. Thank you.
Thank you, Councillor Chef. Is that the Chef? Sorry. Is there any others? Excellent. I have to do this, but although doing it virtually is a bit stranger than meeting people face to face, I am commanded to ask whether there are any declarations of interest by anyone else that's connected to this meeting.
No.
Good. I like that bit. So that's now behind me. So may we now turn to the minutes of the last meeting, which I think was the 14th of December, was it? It was long ago.
January,
Chair.
January, sorry.
I'm very happy to suggest that we approve those minutes as a true and correct record, Chair.
Thank you. Just for the record, may I have a seconder?
Councillor Richardson is waving at me, but she's on mute.
Very good. We'll take that as a seconder. Thank you. Are there any matters arising? Because I know that there weren't any points of matters of actions, but are there any matters arising that anyone has from those minutes?
Chair, I don't think so. I think the main matters arising with regards to COVID, vaccinations and finances can be dealt with in the items that we've got before us today.
Excellent, thank you. So that's all the housekeeping tidied up. Very good. And now on to the main item of this agenda, and that is to the presentation of the financial strategy from 21 to 22 and beyond. And may I ask, please, who's actually going to begin the presentation?
Hi, that's me. So I'll be doing that.
And me is?
Steve Bloomer, sorry.
Oh, that's okay. So you're welcome to continue, Mr. Blue,
okay.
Steve, if I may call you Stephen.
Yeah, sure. Thank you. So just to start, so thank you for the opportunity to go through this with you. Probably worth just saying where we are currently as we come towards the end of this financial year, and then we'll go a little bit into the next one, and then take some questions. So the NHS has received a funding based on its cost as we've been through the pandemic. So and we were given an allocation. Our allocation for the second half of the financial year was £3.5 billion in North West London, and we've managed to live within that allocation, and will live within that allocation and when we post our final accounts in March, and that will cover all of the normal routine healthcare as well as the pressures that have come through COVID and mutual aid elsewhere. So we have lived within our envelope. During that time, we've also managed to invest in the services, and we've spent just around £350 million on capital, some of which is for new buildings. We've spent a fair bit of maintaining our assets, and also fire safety, but and we've had some quite sizable spend around IT and medical equipment. The system that we've currently had in terms of funding has been a better settlement for, if you like, for the NHS and North West London than the business as usual. So as we start to look towards next year, what we know is that at a point in the year we will move to a more business as usual funding settlement, and we expect that to be the second half of the year, at which time the funding will reduce, and therefore some of the pressures that we've seen before in North West London in the NHS will return, and therefore which is the link really here into the work that we did around the strategy and the approach that we're taking to manage that and those pressures. So I think we've set out in the document that we've sent around our vision and priorities, and you will have seen those before, so I'm not planning to talk to those. But what I think is probably worth just reiterating is some of the bigger aims for the strategy. So firstly, we are looking to through the finances to begin to address any inequalities around funding and perhaps service provision that we've seen across North West London, and that's one of the key aims of this strategy. So we'll be working to ensure that we get the resources to the point of need, and particularly that work has started already now as we bring the CCGs together. We will be looking in terms of working very much around improving efficiency in all of the pathways that we work and all of the providers. So what our overall strategy will begin to pull together, and you can see on page 4, is that we focus very much on our costs, and we work less around some of the transactional work that's perhaps happened previously in health, and we start to focus together on cost and how we make the system more seamless so that we can get it to work together to drive out any costs that that we've suffered from some of the fragmentation of previous systems. So firstly, we'll see from a primary care space, we'll see a lot of work focused around how we get referrals into the correct pathways, how we use new technologies, and how we engage and create a wider access for everybody with the resources we've got. And then as we move into sort of the acute providers, we'll be working hard to get people within using a lot of the benchmarks nationally and locally to get people to the most efficient places. We'll be focusing on that cost base and creating an infrastructure that supports the delivery of the strategy and also the development of their facilities. Whilst from a community and outside of hospital perspective, creating an environment that allows us to get people through the hospital system and reducing the length of stay and freeing beds as best we can to treat patients closer and to home and quicker with faster discharges and improved pathways. We're also going to do quite a bit of work around, again, benchmarking and working to get the most efficient services we can to create greater access through community. And we're doing, again, similar with mental health. And we will be supporting the sort of the national mental health standard as well, where we'll see some increased investment. But while we're doing that, we will continue to work on the cost and the efficiency to create greater access. So there's a coming together of each of those bits to try and create an overall strategy that will improve the cost base, but most importantly, will give greater access to patients and reduce areas where we may have had different access across North West London. So that's a very quick canter through what is on the page, and happy to take any questions or comments.
I know that I have questions from Councillor Crawford and from Councillor Lucy Richardson. Councillor Crawford is from the London Borough of Ealing, and Councillor Lucy Richardson is from Hammersmith and Fulham. So Councillor Crawford first, please.
Sorry, Chair, I was unmuting myself. One of the perils of this technology that I still haven't grasped even now. So apologies, everybody. So I guess my question is just around some of the aims and assumptions and outcomes that I think are listed on page 3 of the presentation, which we've just been through. They're all obviously very laudable. I wondered if we could talk about what you suggest are improvements and opportunities from the system response to the current pandemic. And it lists here examples of digital first for outpatients, low complexity, high volume hubs. I appreciate that we're probably a little bit early in terms of getting those things through to fruition, but could you speak a little bit about what the positives have been through this period and how we may look to develop those? And financially, is there a reason, a positive reason why we're trying to advance those processes over others, for example?
Okay, Leslie, want to start? Leslie, I think you're on mute.
Sorry, everyone. Age. So, hi, I'm Leslie Watts, Chief Executive of the ICS and Chelsea and Westminster. So, thank you for that question. So, I think what we've seen during the pandemic is that actually we've been able to improve the care of patients by both the use of remote monitoring, actually, of patients, so we can monitor them in their own home and actually contact them and adjust medications and things like that. We've seen that actually we can hold outpatients virtually as well. And what that has meant is a couple of things, actually. Some of our elderly patients haven't had to travel. And also that actually our clinical teams, and Mahini may talk a bit about this, have been able to work much more efficiently and productively. The other bit about the digital stuff, it has meant that we've been able to share things much more ably, and also that we've been able to be more consistent right across the patch about how we address some of the pathways for patients. I don't know if Mahini wanted to say a little bit more about that.
Thank you, Leslie. So I'm Winnie Palmer, I'm the GP and chair of Ealing CCG. Just building on that, absolutely. So when you look at GP surgeries, despite the pandemic, we have been able to provide care, and the way we've been able to do it is to be able to do it through the technology, which is both telephone, video consultations, which was an absolute game changer for us in primary care, and then absolutely deliver face-to-face for people who need it. And there will be, as you say, Councillor Crawford, quite rightfully, people who will not be able to access these things digitally, and we have to offer the more traditional ways of seeing patients. But what this allows us to do is to use our workforce more appropriately. And for example, our practice nurses can do monitoring for diabetes, for hypertension, for COVID. I mean, that's been the big thing, is around our COVID hubs. We've been able to look after people remotely, and actually the patients have been able to help themselves with the SATS monitors and blood pressure monitors. So actually this is the way forward, while completely recognizing that we don't widen inequalities.
So, and I think we are going through a process of looking at the areas where, and some of the examples we've given there, where we have invested or tried different things, and we're evaluating them to see which ones have worked the best in terms of quality and from a financial basis, to give us the evidence base to carry on with those. And I think also when you're doing transformation, it also gives where you've had successes like that, it allows people to be a little braver than perhaps they would be as they look forward for future transformations. And I think that's something that we'll be able to push harder as we look to the next stage of these.
I think there was also a question about the low complexity high volume hubs. So you will know that it's been very difficult for us to keep particularly elective surgery going during the pandemic, because we've had to provide COVID-free or COVID-protected pathways for patients. And that has led to us centralising particular pathways for pathways. Trauma and orthopedics is one, ENT, they're mainly surgical pathways, where we have high volumes of patients who need fairly low complexity interventions. And we've centralised those in different hospitals, so that actually we've been able, particularly during the second peak, to put through continue to operate on as many people as possible. Still not as many as we would like, actually, and we are looking at the learning from that to see if how we should continue to as we consider whether we might have further peaks of COVID, how we continue to consolidate that so that we can actually protect elective pathways in the future.
Okay, I'm not sure if we've lost Councillor Collins. Councillor Richard, you are there, Councillor Collins. Sorry.
Yes, I am. Yes.
Councillor Richardson was next, I think.
Yes, she was. Yeah. Sorry.
That's right. Shall I go then?
Yes, please. Yeah, I do apologise. Yeah.
Don't worry. Thank you. Yeah, the document. It's good in the sense that we get a clear idea of overview and aims. But I feel the need for more substantive detail that would give clear insights into North West London and our more local financial perspective. For instance, the 353 million capital investment. Is there more detail available to understand how this is allocated, and the 44 million of other schemes, in particular the allocation of buildings? So could we have that more detail? And then shall I ask all my questions at once? Got two more. Would that be easier?
Be easier, yeah. Providing our colleagues are happy with that.
And the gap, when we get our debt back, the gap in funding in the next half of this year, I just want to know about, we say we're going to working on a strategy to understand and control post-pandemic cost base so we can close the gap. When will that be, and what's the timescale on that? If we could have a bit more detail about that, that would be really useful. And if we could have sight of the strategy and how it will be informed by local allocations, given that different regions are going to have had very different COVID expenditure, and how is there a formula for calculating this? And finally, a question for Rory. Have we got Rory? The point about on slide 4, we've got the difficult point about committing to difficult conversations. What's the engagement strategy to facilitate the more local conversations, and how can this be managed now within the inflated collaborative governance structure? Because I know some people, it's some regions where the ICS is working very well. That's in South East London, that's working very well.
Okay.
Thank you. Sorry if that's all a bit of a mixture, but I know that there's all different bits that you all answer. So I thought it was well to spill them all out.
No, it's helpful. Thank you. In terms of can we get more detail in these dates? We can, and I'll talk a little bit about some of the points that. Sorry, the capital. I'll talk a little bit about some of the points there. So, in terms of the way in which we allocate capital's given as an ICS resource, and we go through a process that where we do it based on our biggest areas of risk across the ICS, and it's capital is spent in the provider sector, and commissioners generally don't have capital. So this is across the trusts, and so in terms of this year that we just that we're finishing, the new builds are across. There's a fair amount of work through Hillingdon, and we can make this a bit. Well, I'll break it down and circulate it later if it's okay. But that'd be very helpful. But in terms of that, we've got a fair amount of work that's going towards some of the new builds across Hillingdon, and we've also got some buildings that we've put in place around theatres and some imaging stuff, and so I'll put that around. The maintenance of the existing assets is primarily the backlog maintenance that goes across the sites. So we've got particular issues around the Mary's site and an Imperial where we've got high backlog there. So you see some quite high numbers for across there, and then across London Northwest and Hillingdon again. In terms of the fire safety, that's largely there is a fair bit across the area, but there was a large amount of work done on the Hillingdon site around fire safety. So the biggest chunk of that is there. The IM&T is split across all of the sites actually, and that is split between maintaining infrastructure, but we have had some new patient systems come online this year. So there's a fair amount in there. But as I say, and I'll split some of the smaller schemes out, but we'll do that. But the process is done across the ICS, and we get a capital resource limit which we work from. But the aim of the process is to make sure that we cover off all of the large red risk areas that a board would see on their board assurance framework, and any of the key developments that they need in terms of their objectives. Is that?
Yeah, it's interesting because I know there are different ways of measuring health per population across the ICSs. So it would be interesting to have that more detail on how need is calculated and what the formula is for it, and how the different systems. I know we have a dashboard. Different other different areas have different ways of doing that.
Yeah, I mean, I say we do it based. It's based more around the provider, based on the providers themselves rather than the area, if you like. So it's based on there, and the driver, and the way in which the capital is funded is depreciation of assets for each of the providers. So most of that is self-funded. We did get some additional national funding as well for things like critical care and some things that supported the COVID response. By and large, 270 million of that is internally funded capital. So that's.
Can I just add something? Sorry, Councillor Richardson. I think the other thing. So just thinking about the IT investment as well. As a system, we made some commitments to each other. So, for example, in the acute units, that actually we would go on to the same digital system, so that we could, when patients are going from one trust to another, that actually we can share their records, and actually we keep them safer, and in the end it is more productive. So that has so by mutual agreement, we've said this year more of that investment will go to London North West and Hillingdon, for example, and that's an agreement between all of us.
Thank you. Yeah, it would be interesting to have to see more details on that and see it written down, because it's quite a lot to take in for someone like me who's not a figures person.
No, yeah, we can. I don't know the process, but we can make sure that's available to you after the meeting. In terms of the question around gaps in funding and next year, and the return to the sort of business as usual, if you like, for finances. It sort of, as of today, we don't have yet our financial settlement for the 1st of April. But what we are expecting, as I think I alluded to earlier, is the first half of the year will look largely like the second half of the year that's just passed, and so all things being equal, that we should be able to land within that number as we have. So we feel, I think the second half of the year we go back to more published allocations. So we've done pieces of work to try and understand what that might be. At the moment, we're hypothecating because we don't have settlements. But in terms of worst cases, we're starting to look at gaps of around £200 million, that sort of, to give a sense of that. Now, what's helpful about the having two halves, if you like, and it gives us the time to put in place efficiencies and schemes to we've got 6 months to get ourselves readied for that, so that as things change, which gives us a chance to make sure we are we're delivering there, and those will be a mixture of sort of traditional cost improvement efficiency schemes that you would normally see in organisations, and also we'll be working across more of the transformational schemes. Now, I don't have a huge amount of detail on some of this because we haven't got, we're a little short on the numbers that we're working towards, but that's fundamentally the way in which we're sort of working on that. Teams in the individual trusts are working through their responses to this, as well, and we expect to be, to be in a good position, sort of within a few weeks actually, to describe how we're going to sort of bridge that gap. That's broadly where we are now.
I think we'd be interested in seeing that as a committee, as what that looks like, overview, because I mean, I know before the pandemic started, there was a lot of we had a lot of talk about efficiency savings, and already the services were quite pared back, and it's obviously very concerning how we're going to manage to pare back even more. I understand that there are some savings that have come from the developments, but still, it's a sobering thought to have to deal with that.
I think it is, and I think there's a key role in this for, in terms of some of the practice that was in place before around making sure that all of our schemes are quality checked through the, usually through sort of chief nurses and chief medical officers, and all of those things will be bought, we'll be continuing and pushing with, so that we make sure that we don't have any unintended consequences for this. And I think that, we have got some work and some things that people have started, but I think the thing that we've got now that perhaps we didn't have before is that actually, firstly, we are focusing on the cost of provision within the system, and we're not focusing on transactional things or competition amongst ourselves. And with that, we've got in place some really good transformational leadership across the system, which has delivered some of the things that Leslie touched on earlier around the way in which we've done we've worked together. And I think we will be working quite hard to use that, and I think that will open up some opportunities that we've not had before, to think about how we how we deliver services in the best way, perhaps in one place or what have you, but we've got opportunities that we've not had before. So I think that's the thing that's going to be different for us, that should allow us to get into some of these, and I think that pushing ourselves so that we're all at the best that we can be across the whole of the area. So there's a lot more openness around efficiency and around the way we're thinking than perhaps we've had before, and that sense of almost like peer pressure to get ourselves up. And so there's a few things that we've not had quite so openly and that we've got in this coming financial year, which we'll be hoping to make sure we use well.
Thank you. And those things do all sound, all that collaborative working is very encouraging, and, obviously does reap rewards. But we would, I think we do need to, we would like, as soon as you have those figures, to have them shared, because I can see other councillors have got their hands up, so I'll let them.
Did you want me to talk about engagement before you go to the other side?
What do you want to do, Councillor Collins? Should we see if there are other questions or follow-ups on this, or shall I let... go ahead, Rory, then.
Okay, so I have talked to this committee a few times about engagement, the EPIC programme and community voices and all the work we've been doing. So that's developed quite a bit during the pandemic. So you will have seen we've been holding a lot more meetings with members of the public, but also going to where the public are, which is a lot of the principle of that. So really the principles are around co-production, around working with people as opposed to sort of doing to people. And I think we've started to embed that. There's a whole piece of work which I think some councillor is involved with around tackling vaccine inequity and looking at inequalities. So that's a really key part of this, and thinking about how we reach our different communities, but hearing from them, not just going out and talking to them, not just going out when we want to change things, but trying to build that relationship. In terms of actual changes that are proposed, we are developing a set of principles around service change at North West London level. We developed through the EPIC programme a draft involvement charter, which we're happy to share here once it's been sort of finally signed off. And we would also look at having representatives. So if there was a piece of work to change a service, make changes, you would look to have public representation on those groups as well as going out to talk to the public about it. So you'd look to have members of the public represented and involved early in that decision making. So it'd be a best practice-based approach, very much based on the things that we've talked about here before. I'm happy to talk about it in more detail at another meeting if that's helpful.
Thank you. I suppose we're all worried now with the enlargement of the CCG that we keep that local voice and that
and we do have representation at each borough level of engagement staff, dedicated engagement staff to work within their boroughs and their areas.
Thank you.
Okay.
Councillor Collins,
hello.
Would some of I could ask a follow-up question, but I'm aware of time.
Assumptions, which Stephen dealt with earlier. Unfortunately, my Wi-Fi has been really bad. So Leslie might have dealt with this already in response to Lucy's question, but let me ask anyway. And Leslie, forgive me if you have already dealt with this. I only heard the tail end of your reply. So talking about allocation, which Lucy was asking a moment ago, I'm interested in finding out what has been the COVID-19 allocation for North West London to cope with the extra cost pressures, which Stephen has been highlighting for us. And what is the state of finances for the provider trusts? And then I also want to ask a slightly forward question about the current state of deficit and surplus of the 8 CCGs, and how are they going to be assisting in contributing towards filling that financial gap as we move forward, please? And then once you've dealt with that, I'll come and ask those two questions under the theme around aims.
Okay.
So sorry, no, Steve, actually, I'm really happy if you can answer this, because it sounded like a lot of figures to me and I'm probably underqualified. So Steve, you go.
So in terms of the COVID allocation for the second half of this financial year was just around £170 million was specifically allocated to us as a system. The first half of the year was done more on a retrospective top-up basis, and that was just shy of 200 million in terms of what went through in terms of cost. And there are some things that have been provided that aren't included in that, which would some of the larger PPE things which have been which are central to it. But that's the allocation for us. In terms of so that's covered a couple of things. That's covered some of the costs around you know, some of the setup, and also it covers the costs where, you know, people have had to put on extra staffing in areas and extra beds, things like the critical care in particular for the second surge, and the sort of work we've been doing around, you know, what might it look like in terms of ongoing cost or loss of productivity, you know, after, you know, and sort of as we move into the next phase. I would expect, you know, we think it's about 15% lost productivity, that sort of number, possibly a little bit higher initially, but that's the sort of target in terms of and in terms of sort of cost of the ongoing sort of COVID that we will have to manage from within whatever allocations we're given. I think the question on the CCGs, the CCGs will balance or you know, and have hit their control target across the patch. So again, like the providers, we'll finish on if you like on a break-even position, which is an excellent effort on where from the teams and where we wanted to be. There are a couple of pressures that we're obviously aware of going into next year, so we're very conscious of some of the costs and some of the increases in some of the placements, but we're working on that with people, and generally some issues out of area type issues that we're working on, but fundamentally at the moment we are in balance, and we expect that to sort of carry on into next year. Does that answer your question?
Thank you, Stephen, for that. Thank you. Chair, are you okay if I ask quick 2 questions around aims?
That's fine. Please go ahead.
Thank you.
I'll go on to the next people.
Thank you. So I'm interested in following up to Dan's question around aims and assumptions. So I'm interested in finding out how will reducing the clinical variation, what will reducing clinical variation mean for healthcare services generally going forward? And is there going to be, and this is my second point, is there going to be any shift in resources to places like Brent, for instance, to deal with what Rory was describing earlier about health inequalities? And is there going to be, going forward, is there going to be any extra resources allocated to those populations to deal with those challenges?
Okay.
Thank you.
So in terms of the when the CCGs was part of the vote and the process, we made a commitment to putting extra money into a number of areas, which was about £28 million, and we said we would do that over 4 years, and the first year is next year, and we have made that movement in allocation, so we will see more money going into those areas, in line with what we'd committed. So it's about, so I say, £7 million, and that goes into allocations next year, and we're working through the detail, but that is what we've already started to do. I think, and obviously, if we can go further and faster, we absolutely will. That was a set of commitments around, I suppose, the slowest pace, and so we are. We have that all started. We're also doing, I don't know, in terms of the clinical variation point. I think this is around, how this sort of helps from a financial perspective is that it helps us if we're using the right pathways and we're getting people into the right place. So cutting out people going into secondary care if there was a better pathway for them somewhere else, only to bounce out and have to find that pathway. So there's some particular issues around that, and I'm working with people to make sure that we always get that most appropriate call first time. And actually, although that sounds like a small thing, it does create a lot of space clinically in terms of particularly in outpatients. And that's particularly useful with time that can be reprofiled in the acute units to other sort of interventions, whether that's in their job plans. So it does allow us to sort of improve the system. And we'll be working and supporting that, and we're putting in place some support across the ICS in primary care, in that sort of, and to particularly to try and land that, and work with all of our practices to ensure that everybody is working to this across the similar sort of rules or pathways, and everybody's clear on where and how to land that. I don't know if there's anything.
So Steve, can I just, Chair, would you mind if I just intervene just a minute? Because I think this is a really important question, actually, and I do think we need to be reasonably explicit about it, which is But and this is something that we've talked about with our local authorities as well, which is our intention to address the inequalities that have been writ large. That we knew about them anyway, but have been writ large during the pandemic. We know the outcomes for particular groups of patients, be they poor and deprived, be they from our BAME communities, have worse access and worse outcomes patients. We're pretty determined together to address that, and I guess I'd ask for your support in that. Excuse me.
Thank
you very much.
You will get our support, yes.
Thank you very much. Chair, thank you very much. Can I just say thank you to Stephen and Leslie, and particularly Leslie, for supplementing that response. But I just wanted to come back, if I may, Chair, with your indulgence, very quickly, and a very quick point. This is a very quick point. I just wanted to ask and get that comfort. Is there going to be, Stephen or Leslie, any shift in resources to deal with what you have very helpfully described? And as you just heard the chair say, of course, we are all going to be supporting you in that endeavours.
Yes. So over time, yes, there will be.
Thank you very much. Thank you, Chair. Thank you, Leslie.
Yeah. So is it Councillor Al-Maghi from Kensington and Chelsea next?
If you don't mind, Chair, yeah, thank you. Thank you very much for this presentation and engaging with us and highlighting some of the key issues here in the vision for the future. And I hope this 1 year now, almost, on this pandemic happening, which or on the almost reaching a peak point where I would like to see in this strategy the staff addressing these changes. What kind of support, which I could not pick up, the staff fatigue, what kind of support in terms of this integration and if we look at the when we are merging or any changes happening within the overall system, we're looking at saving, of course, using technology, but this technology needs staff training. We have people going sick with very high skills. How these gaps between supply and demand has been addressed. What kind of impact is being built that strategy as a contingency to move forward? I would like to have some answers, if you don't mind, please, there.
So thank you, and actually thank you for that question, because I think it comes from a very good place in terms of us thinking about the well-being of our staff. So one of the things that I hope we can send you actually our strategy, because we've agreed this across North West London about the support of our staff, both in the ways that you've suggested following the pandemic and the impact of the pandemic, the need for rest, recuperation, and to build resilience. We spent a good deal of time across the whole patch, be that for our staff in our CCGs, for our primary care colleagues, and indeed for the staff in our provider units. And we have shared that actually with our local authority chief execs and social care leads as well, because it's something that we've been in together. So thank you. The other thing we've learned during this pandemic is that actually, and staff themselves have learned, is that actually they can do things that they never thought they would have to do. And so there's a bit that says, how do we build on actually so how do we help them repair from the negative impacts of the pandemic, but also how do we build on the amazing actually inspiration they themselves have garnered from getting experience, being developed, getting training, and doing things they never thought they could. So, and we're just in the middle of bringing that packaged together. But in the immediate bit about their overall health and well-being, we've done a good deal of work, and we will share that with you if that is helpful.
Thank you. That's very important, yeah, because I'm addressing this on my next committee meeting next month. So thank you, Leslie, for this. Thanks. Thank you, Chair.
You're welcome.
Now, I'm conscious of the time because I thought this item would engender a lot of debate. But I wonder if I could actually suspend it just for a few moments for Leslie to do her bit before you have to drop out. Leslie, at 4 o'clock, am I correct?
You are. I'm going to be questioned by some other very kind people in a minute as well. I was going to talk, I think, about the white paper, and we've got Pippa on as well, if you want to talk about vaccinations as well. So, as you know, during this year, we've also had the publication of the white paper from the government. And I just want to talk to you a little bit about where we are in thinking about it and what's encompassed by it. So the suggestion is that integrated care systems will be put on a statutory basis, and that will bring together the commissioning function together with our providers of all of our NHS services, but also in partnership with our local authorities and other partners. And we together will have a duty to plan and improve the health services and the care services for our local population. So for overall our population of North West London in this case, but also for the very important and varied populations of our 8 boroughs. Also in that is, and I can't remember the question, but there was something that spoke to this, is will be in place, and we're ahead of some of this, as you know. There will be place-based partnerships. Actually, I think it was Lucy that said about the worry about losing that localism with the consolidation of the CCGs. But
yeah, we did.
Actually, following really important discussions with each of the boroughs and the need and recognition of, we wanted senior leadership in each of those. We've put together our place-based partnerships between our local organisations. So in our local communities, we have our mental health colleagues, our community colleagues, primary care, and indeed our local authorities are part of that place-based management and delivery arm of the ICS. And that's working pretty well. Some boroughs already more or less had that in place, and we're ahead of the time, but now all 8 boroughs have that in place. And for us, we put them in our borough boundaries, which made it easier for us. And they're nascent in a way, but actually the way we've been working, I think, speaks to that. And each acute unit may well be bound into more than one of those, obviously. We've also been working as provider collaboratives. As you know, across North West London, we have 4 acute trusts. So we have the hospitals of Imperial, Chel West, London North West, so Norfolk Park, Ealing, and Central Mid, and we have Hillingdon. And to be frank with you, the reason that we have dealt with, as you know, North West London was really hit hard by the pandemic. The reason we dealt so well with it, putting aside actually a magnificent support from our local authorities, our community mental health and primary care colleagues, was the way that the acute providers collaborated together to ensure that we had enough critical care beds, to ensure that we moved staff to where our sickest patients were. We shared kit. Actually, we continued to operate on some elective patients by moving them into other units. All of those things happened because we collaborated so well together, and we're pretty determined that collaboration will continue and indeed will become closer, so that competitive environment in which we worked before, actually we've changed that to say actually we will gain more for patients, we will drive up quality of care to patients if actually we work much more closely together. And so we are determined to do that. And in the white paper, we will get further guidance about how any statutory a context of that will come out later this year. And then I guess the other big bit was regulation. So NHSE and I are likely to come together. We will still have the Care Quality Commission, who are our major regulators right across through health, as you know. That we will still sit under the Department of Health and Social Care. But actually, they, instead of working with individual providers, so in my case, Chel West, they will actually look at how the system functions together. So we will be working together and holding each other to account. And again, in North West London, we had already set up the environment to do that. So when we have a look at our providers, actually our community mental health colleagues are in the room, as are our GPs, our primary care colleagues, as are our local authority and social care colleagues. So we've already done quite a lot of that work. And that's the bit we do need to do more work on is build up our primary care networks, build up our work in local neighbourhoods, actually, so at a more local level even than our boroughs, and join up our primary community care services. In essence, that's what's encompassed in a much bigger document, actually. We've had first talks with your chief execs about this. I've done some presentation with your leaders on this, and I'm happy to come and talk about it in much more detail at a later date. But that, in essence, that's what's garnered into that white paper.
Leslie, do you have time to take 2 questions?
Of course, of course.
Thank you. Councillor Lucy Richardson, I know you wanted to ask a question on mental health, and I believe Councillor Saunders wanted to do a follow-up question on around the same thing. So Councillor Richardson, please. Is she muted?
Yeah, no, sorry, I unmuted myself, then muted myself again. It was Councillor Saunders who had the question about mental health, actually.
Councillor Saunders.
Yeah.
Yeah, thank you. My question about mental health was really back to the previous agenda item, to be honest. So that was really, we need to move on from that because obviously we don't have time to do that. My question is about ICS. In Richmond, our main trusts are actually, we don't have hospital trusts in the borough. So our main trusts are West Mid and Kingston and Chelsea and Westminster. So from the point of view of West Mid, for example, we are quite a small cohort in their bigger fish, and but they are a big fish for us. So how is that going to work with neighbouring boroughs? But obviously that's an issue across the whole of London. How will ICS's work and the partnerships work on a collaborative way when you're just a small element of their business, of not business anymore, is it really? You're muted. You're muted.
You know, some people just never learn, do they, actually?
2020, hasn't it?
So thank you for that. I mean, I think it's a really interesting question. My take on this, and as you know, West Mid is one of my own hospitals, is that every single patient that comes in there ought to have the best possible care that they can have. It doesn't matter to me, as the chief executive of that hospital, whether they come from a CCG that provides 80% of our work or a CCG that provides 20% of their work. And actually, we don't even look. We wouldn't know as those patients come through. Well, the bit that the ICS needs to do, and that, just to reassure you that we're working very hard at, that relationship between, in this case, West Mid and the community and primary care services in Richmond, to make sure that work is joined, that patient pathway is joined up, is very important to us. And just again to reassure you, we are working with Richmond and Kingston Hospital actually, and with HRCH to make sure that we're doing that. So if anything, I'm hoping that the ICSs will actually coordinate that care better, not make it worse. And you have my commitment that it doesn't matter the proportion of the work that comes from any one of the boroughs.
Okay, thank you. Thank you.
Is there any other question to Leslie before she has to go? Or if there are, perhaps you'd like to write to your coordinator, and then we can coordinate the questions and send them in if that's acceptable to Leslie. Yep, you
Thank
agree?
you. I'm leaving you in good hands. Thank you very much.
Yeah, thank you. I want briefly, if I may, to go back.
Thank you very much.
I'd like, if I may, to go back to the previous item, because there was one outstanding question from one of the colleagues. If they would like to ask it, I'll be happy to allow you to do that, and then I'll ask Pippa to talk about vaccinations.
If that was me, Councillor Saunders? I was going to ask about mental health. I really just wanted to.
Yeah, please ask it now.
Thank you.
You're more than welcome.
Thank you. It was really, if you could say a bit more about mental health, because I think, other questions have touched on this, I think, to an extent, in terms of health inequalities, deprivation, and so on and so forth. And thinking about post-COVID, the level of homelessness, the level of unemployment, debt, domestic abuse, youth, young people's mental health, and also social prescribing and the social prescribing agenda, which seems to sort of be quiet at the moment. So I just wanted to find out really a bit more about, when you talk about investment in mental health, what that actually means, taking on board inpatient, outpatient kind of priorities and so on.
Okay, thank you. I'll start, and then maybe might call on Joe Mahini to help out on some of the more clinical detail. But in terms of the from the financials, we are pushing sort of mental health forward, as we've said, we will be putting additional funding into, which is in line with the mental health standards. So as a minimum, we'll spend £20 million more next year than we do this year in terms of mental health spend, and that will be worked on with the provider teams that who are working as a collaborative, and also the primary care teams, in terms of where we need to put that funding to increase the access. And a lot of that is in line with a set of long-term plan aspirations for mental health. That you touched on after COVID, and I think there's an acceptance that there'll be a greater need after COVID for mental health. And my understanding is there will be a separate national fund, which is probably about £1.5 billion across the country. We would obviously get some access to that in North West London. In all the things that we've done from a financial thinking or planning perspective around what our gap might be, our assumption is that whatever funding we can get in for the mental health will definitely be spent on that, because we recognise some of the issues that you raised. Where obviously we're not sure how much we'll get, but if you do it on a pure dividing the country down by population size, you would expect something like £50 million to come to an area the size of North West London. But that's that's sort of in terms of from a financial investment perspective. Joe, do you want to add anything in terms of?
Do you want me to come in, Steve, and
yeah.
And health? So from a clinical perspective, absolutely. So this is well recognized, the issue with mental health provision for multiple reasons, whether it's work or whether it's isolation, and this is amplified further in children, and that's also well understood. One of the things we've got to remember is that we were in a national lockdown, so mental health services for people who did not need an acute response, a lot of it was being done virtually, which is also, I think, recognizes that you can only take it so far, and the same thing goes for social prescribing and social link workers, because you couldn't have people visiting people in people's homes, and all that thing is still in place. Having said that, I would say that mental health provision and the best delivery happens at a borough level, at a place level, closer to the person's home, wrapped around, where they mainly access care in and around their GP, their pharmacy, their church, their faith place, etc. So when we look at integrated care partnerships, what Leslie was talking about earlier, in each borough, everything should have mental health underwritten and threading its way through that, no matter which service you are providing, because it is so integral to everything that we do, and I think that is recognized. Certainly for Ealing, which I know very well, you absolutely have it integrated within there, and I would expect my mental health providers to be equal partners in provision at the local level. And for people might be aware that we are getting some additional mental health workers who are going to be working as part of increasing the workforce in GPs, and that's being worked through the model at the moment from 21-22, working with our mental health providers, so not employed by GP, but actually working embedded in PCNs, and that builds on the PCN work. So I think it is recognized. I think mental health has a journey to get to equitable funding, because that then needs to translate into workforce, which always takes a bit of time, but I think it is well understood.
Okay, does that answer your question, Councillor Saunders?
Yes, thank you.
Okay, with members' agreement, may I now please go on to the other part of our agenda and ask Pippa to give us an update on the vaccination programme. And welcome back, Pippa.
Thank you. So I'll be brief and then I'll take questions. So just brief headline numbers. So we have vaccinated 735,000 people with their first dose of their vaccines in North West London. Today's been a good tipping point, actually, because we've achieved over 80% on all age groups above 60, and some of them way above 80. Some of them are sitting at 90%. So we're in a good position with most of them. We have got 8 very different boroughs, and I think what we've learned is our approach needs to be different with each borough. We've got different populations, and we really understand them populations actually and how they're starting to access vaccine. So what we've now developed is 8 individual borough plans that have been devised between health and local authorities, so that we can deliver the vaccine in the way that is required for that population. And some of that is having to be more mobile with the vaccine. So we have run over 150 what we're calling pop-up clinics, but these are taking the vaccine to the communities. Some of these are tiny, so some of these is 1 vial, so 10 doses of a vaccine going to a particular church hall. But actually that's 10 people that have been vaccinated that were hesitant coming forward. Others are larger. So today we've got Hounslow Mosque that are running a vaccination service there. We've got over 100 vaccines being administered there today. So of different sizes, but these pop-up sort of roaming models are absolutely the way forward to make sure we get right into the communities that we need to vaccinate. So I think I'll leave it there, but I'm more than happy to take any questions.
With colleagues' permission, could I ask 2 questions? The first one, of that 700,000 that have been vaccinated, can you give us an up-to-date figure of how many or what percentage of that have actually had their second dose? And you've touched briefly on the question I wanted to ask, but I wonder if you could expand a bit more of how you're getting the message across to the ethnic minority communities that appear to have some kind of stigma attached to receiving the vaccine and some kind of fear. I want to ask my question very delicately because it is a very delicate situation, but we need to get their trust, because if we can get their trust in the vaccination, we can also perhaps gain their trust in other healthcare needs.
Yeah, absolutely. So in terms of a second dose, so we've currently got 19% of the population that have received their second dose. We only started giving second doses blanket for everybody 2 weeks ago, because that's when the 77th day was from the first vaccine. So we're just starting. The whole of April will be focused on giving second doses, because we've got thousands to give in April. So that's what we'll be focusing our efforts on in April. Your question is really relevant. So I think it's important we don't take a blanket approach, because actually what we've found is there's very different religious communities, and actually even in a set religion, they are very different in different parts of Northwest London in their approach to vaccine. So what we've done is some really bespoke communication with religious leaders. Our religious leaders have been really, really helpful. And really supportive of us, using their facilities, but also supporting the trusted populations to come forward and be vaccinated. So what we saw at the start was a real hesitancy from some religious groups, but actually that is becoming less and less. I feel like we're breaking through some of the barriers actually. We've got some GPs that have been real role models in this. So I think it is very much the promoting some of our different ethnic groups being vaccinated, and some of our own GPs have done a really good job of that, and they've filmed themselves being vaccinated. They've filmed little clips in their own languages that we've broadcasted out, and I think it's just lots and lots of different approaches to communication that we need to keep doing. We will carry on doing that, but I would say the engagement from our religious leaders has been very supportive.
Thank you very much. Can someone tell me whether there are any hands up, please?
I don't see any, Chair, but I did have a question, so
yes,
perhaps
please,
I could ask it. And then I've got Councillor Richardson, and while I'm asking, I'll open the gallery view and see if there's anyone else. Pippa, one of the questions that came up at our own local health scrutiny panel in Ealing was about the original distribution of the mass vaccination centres and how that was decided. But I think you partially answered it in terms of what you said in your overview with regard to how you've got this flexibility to bring in smaller, more mobile vaccination points. Can you just talk a little bit more about the process behind how it's decided where those resources are placed and what discussions take place? And then I assume it's based around where you need, who you need to vaccinate and where is appropriate for them to get to. It's just with some people still shielding and some people not being able to travel, those needs are really pivotal. Thank you.
Thanks. So the decisions we made actually quite early on in this programme about where the vaccination sites were going to be, and there was a set criteria that was set by the National NHS England team around what a mass vaccination site needed to agree to, which actually ruled out many buildings in North West London. So they had to sign up to a lease contract with us for at least 9 months. Now, a lot of the venues that were interested only wanted to do this for 3 or 4 months because they, thinking as soon, and we've got that right now, and some of the hotels we're using, as soon as we come out of being able to socially distance and they can now go back to normal, they'll want their normal business coming through there. So actually it ruled out many buildings that we had our eyes on at the start because they couldn't sign up to that long term of lease. The other thing was space, so socially distancing, one-way systems, car parking, travel, there were all sorts of criteria. The other one, just to be completely transparent, was generally cost. So we did have a lot of estates that were putting themselves forward, but they were way outside of the costs that we would want to pay within the NHS. So some of them being pragmatic, but actually what we've done is work around it. So the vaccination centres are not the answer to everything, they're really not. And what we've seen is now local pharmacists popping up, which have been great in Ealing actually, but the more local pharmacists we get, they do smaller volumes every day, but it does mean that people are having to travel less distance and actually they really are accessing them. And then supported by these pop-up models, which are definitely the way forward, so we can actually take the vaccine to people who are hesitant.
Thank you so much. Councillor Richardson had a question. Councillor Collins, I'm going to ask her to do it now, and I'm not sure if Councillor Saunders had a question or not because I can't quite see it, but Councillor Richardson.
Yeah, we'll take Councillor Richardson and then I'll ask Councillor Saunders. Yep, thank you. Go ahead, Councillor.
Thank you. Yes, you mentioned that emphasis being on faith groups, engaging with them. I think our concern in Hammersmith and Fulham is that we've got a history of lack of trust and low up and very low, extremely low uptake of vaccinations in our borough, especially with BAME groups who. And it really needs to sort of, we've had not just the COVID vaccinations, but before that, it's gone back for quite a few years. What sort of programme are we? I mean, as we're doing things as a council with different faith groups and voluntary organisations, groups supporting children and young people on the local radio. But I suppose my question is really, what particular strategy have we got for Hammersmith and Fulham? Has the CCG got for Hammersmith and Fulham to deal with this?
Yeah, so there's 3 boroughs actually that we're doing a particular focus on. So Central, West and Hammersmith and Fulham. We can't just presume BAME groups actually, because the biggest hesitant and refusers of the vaccine in them 3 boroughs are not BAME groups. They are white.
Yeah, I suppose what I meant was really to dig into this historic lack of engagement.
Yeah, so I mean, what I would say is it's not one size fits all. So that's why we particularly need to have the borough plans, because the borough plans are very different and niche to the population that are living within them boroughs. So for Hammersmith and Fulham, Central and West, we've got a plan that we've just piloted over the last week that's been extremely successful. So we've tried it in Central. We've done it for 4 days, and what we've had is we've linked local authority staff with our primary care staff. And what they're doing is having conversations. So they are contacting every single person that has not had an uptake in the vaccine in groups 1 to 9. And we're having conversations. So some of these are our directors of public health that are having conversations around with people who are hesitant of having the vaccine. And what we've seen in the 5 days that we've done that in Central is a real uptake in the vaccine. So for the 70 to 75-year-olds, there's been a 22% increase in the vaccine uptake in the last 5 days in that borough. So now what we're going to do is just roll that out across them 3 boroughs, because I think that's now the detail we need to get to. We need to, rather than going down the cohorts, which is the easy pickings, we actually now need to spend more focused time trying to get people to come forward and be vaccinated that are in these vulnerable groups of 1 to 9 that we're vaccinating. So they will all be receiving individual phone calls and conversations where they've got time to really have that discussion now around why don't they want it. A lot of them are actually, what we're hearing is we're concerned about their long-term condition and the impact it might have on the long-term condition. So it's detailed individual conversations that we need to get to that base now, and that's what we'll be doing with them 3 boroughs.
And obviously that's going to be really useful data. How's that going to be captured?
So that's part of the reason for doing it. So we have talked about them boroughs having a complex population, that many are not currently residing in them boroughs. So they may be registered with the boroughs, but they're not currently living there. But actually, we've never been able to put a number to that. So while they're having these conversations, they're actually then documented why, if they haven't if they don't want the vaccine, why don't they want it? And actually, are they currently residing in North West London? So we'll be able to say exactly what proportion of the people are not having the vaccine and for what reason.
So that data will be available to each borough.
Certainly will.
That will be very useful. Thank you.
Councillor Saunders, please.
Hi, thanks, Pippa. I think to some extent you probably answered a bit of my question. I mean, this is based on my personal experience, and I know that most of our enrichment comes from Southwest, but the opportunity to book online through the NHS system, which is what I did, you have to do the first and second vaccination at the same time. And probably for the very reasons that you initially started talking about, the actual locations for the second vaccine are very, very far and few between, and quite a long way for someone like me who doesn't have access to a car. So it's a pharmacy somewhere down near sort of Hounslow, Hillingdon. So I was just, wondering really how, I was advised to book it anyway and then cancel near the time. So my first thought was, hang on, there's going to be lots of cancellations going on as more centres come on stream, maybe near the time, and whether that's going to cause, sort of confusion, duplication. So that was one thing. The second question really was, we've still got, this is probably more for Southwest, it's unfair to put your way, but there's still quite a lot of people getting duplication, notification letters through the national system, and through, secondly, followed up a few days later by their GP saying, can you please book a vaccination? So there's still some kind of crossover going over. And my third issue, which is not really fair because it's not about vaccination entirely, was really about and I'm not sure that should be directed at you, but there were some issues to do with liaison within the high dependency wards of patients, or lack of liaison, should I say, between in the high dependency wards and relatives and next of kin. But that's probably not your...
No, that's fine.
Maybe.
That's fine. So I think second appointments have been challenging for people. So what we've currently got is more capacity opening as the weeks and months go on. So I know some people in the national booking system can book their first, but their second is further away. If you book into a mass vaccination site, you can also always get in for your second. It's the smaller sites that are struggling. So what we've been saying to people is just nearer the time, relook, and you'll have an opportunity to change it. So we need to get that comms out to people nearer the time, but it is important people book it just because it's that trigger of remembering when it is. We haven't had the problems with communication in North West London, I have to say. So the booking system communication hasn't been an issue that we're aware of. So I don't quite know what the problem is there. But in terms of what I would say, so our site in Compass site, which is at Heathrow, has been pretty much 100% booked since it opened a week and a bit ago. A lot of the people coming from there are Twickenham and Richmond. So the majority of people using that site are Twickenham and Richmond site. They're not actually North West London. Now that's fine for us. It doesn't really matter who we vaccinate. The more people we get vaccinated, the better. But people are travelling from quite a way to come to be vaccinated there. I guess it's an easy access, lots of car parking site. In terms of communication, we're very aware of it, and it's not been ideal. We can just only admit that. I think what we've had is actually in ITU, the communication has been very good when we've had people in intensive care, because what we had is family liaison teams in our intensive cares, and they made the daily phone calls to the family members, because actually, quite frankly, our staff couldn't do that. They were in their PPE, they were stuck in the room with the patient, they could not be making phone calls. So we deployed many of our teams, some of these being like orthopaedic surgeons, lots of different people that actually couldn't operate at the time. So they were deployed into ITU to be this family liaison service. So I think when people were in intensive care, actually, it was good communication. It was when we had people in what would be our high dependency units, or actually they were just very acute wards that were having non-invasive ventilation. So they were sick, they were really sick, and they were on busy wards, and the communication was not ideal for that. And I think we've done a lot of apologising to families where we've had the opportunity to. But I think, if we're doing our post-learning of if we go into another wave, what do we need to do better? It is definitely a different approach to communication, because I can't imagine how stressful it must be having a family member sick in hospital and you just can't find out how they are. And I think it is that small proportion in the middle, because actually the patients who were well enough to make their own phone calls were communicating. The patients that were really sick and on ventilators had a liaison team, and it was this small group of patients in the middle, actually. So I think what our solution is, that liaison team need to cover the high dependency as well as the intensive care, so we can get that communication better.
Thank you. Thank you.
Right. Can anyone tell me whether there are any more hands up, because I'm acutely aware that it's 27 minutes past 4 on my watch.
Yes, Chair. So I've got Councillor Richardson, Councillor Al-Nagi. Councillor Richardson is saying no. So just right. Councillor Al-Nagi.
Yeah, Councillor Al-Nagi. Well, we do have time to take your question.
Okay, thank you, Chair. It's very interesting, and thanks, Pippa, for this, all your hard work, which I have first-hand experience. I've been vaccinated a couple of weeks ago, and at St. Charles Hospital in North Kent, and it was an experience from an operation and welcoming. It's nice to see many people on that Saturday being queuing in a very ordinary manner, getting their vaccine on from all kind of back, which is for me as well to get vaccinated. So I really congratulate you for a fantastic, swift, very clear operation. So I hope all the other centers are the same. Now, my question is regarding the pop-up. Is regarding the strategy of that pop-up, how is being replicating that normal vaccination process as experienced myself at St. Charles. And the second thing is I thank you on behalf of our borough opening the Science Museum for vaccination for our residents there. I think that's a really welcoming move. From what we see, it's a quite good advanced stage. But I'm more concerned on the pop-up, and how can you shed some insight for us, please?
That's fine. Yes, the Science Museum being very popular. So they did 1,200 and something vaccines there yesterday and about the same today. So that's been a very popular site. And the Science Museum have been so supportive of us being there. In terms of the pop-up, so these are done in very different styles. So some of them are literally going to houses. So it's a single roaming model where it's one person going into a house to vaccinate someone who's housebound. Others are going into a GP practice, so a small GP practice where the GP is invited in a small number of patients and they're vaccinated in their own local GP practice in this pop-up style. And then some are a lot of them are in religious buildings or church halls or school halls or just small buildings where we can bring a smaller number of people to be vaccinated. They're all done in a very similar way, so the same professional standards, nothing different really. We just literally set up a temporary little clinic, vaccinate them all, and then that just gets taken down that day. We don't store any vaccine on site or anything like that. We just take everything to the site, set it up, vaccinate, and then come away. But I think that what we're hearing from some of our residents is, you have to remember people have been shielded and in their house for months. To suddenly tell them to come out, get on a bus, get to a centre that's away from them, that's a big step. Whereas if you tell them to walk a few minutes down the road to their local village hall, they're much, much more likely to do it. So that's why we've been doing it in that style, and they've been really popular, really successful.
Thank you, Pippa. That's really encouraging. That's the same standard rigidity is being followed there, because I've been invited to see one from our very large local organization, which is very encouraging to see that. So hopefully we can address these issues, as Councillor Collins highlighted earlier, regarding different ethnicity, and we have a very large proportion in North Kensington here. So thank you very much for that approach and clarity. Thank you, Chair.
Thank you. Councillor Crawford, is there no other indications?
I've got two more that I neglected to tell you about previously. Councillor Chowan and Councillor Sheth.
Could I just check with Pippa that she's okay to stay with us for a little longer?
Couple more minutes. I have actually got to go straight onto another meeting, but I'll quickly do a couple more questions.
Right. Can I take Councillor? Sorry, I didn't catch the name. Councillor Crawford.
Councillor Chowan was first.
Yeah. Yes, Councillor Chowan, and then Councillor Sheth, and then I will say my goodbyes to the officers on your behalf. So please go ahead.
Hello.
Hello,
Hi.
Councillor.
Hi. I just wanted to extend my thanks, following on from Councillor Nalgi, that you've done a wonderful job in Kensington with the mass vaccination hub, and I hope to support that myself. Also, I wanted to just ask a question about your outreach work. You've talked beautifully about all the work you're doing, going into houses, going into GP practices. But is there a roving service like the Vaxi Taxi thing, kind of in the horizons in the next few months?
We've already got a Vaxi Taxi. So we've got Vaxi Taxis that have been going out and vaccinating, which is great. We've had lots of support from local transport as well that have been taking people to be vaccinated or taking vaccinators to the people. Lots and lots of different approaches. We've had a very different approach to vaccinate the homeless, and we've just got to be more dynamic and do this in lots of different ways to meet all the population that we need to.
Yes,
thank
you very much.
Councillor Sheth.
So that's it, really. I think the rest of the questions you've answered that I had. Thank you very much. Thanks again.
Thank you. Councillor Sheth.
Thank you, Chair. Pipa, you just dealt with part of my question. I was going to ask you about homelessness and the work around it, but before I do, let me just add my thanks and thank you for all the wonderful work that you and your team are doing, and thank you for visiting when. So very quickly, before you have to go to another meeting, if you could just very quickly say something about your work in care homes and the variation, and just say a little bit about homelessness. How are you engaging with them? And perhaps if you have to go, then Rory can pick that up in your absence. Thank you.
No, that's fine. So care homes, actually, we've been very successful. So we've got 91% of care homes residents vaccinated currently. Now, obviously, that's a continuing programme because we have new admissions into care homes every week. So we have to keep going back in to make sure new residents in care homes are vaccinated. And we had a number of residents who were within their 4-week period of having COVID, so couldn't be vaccinated at the start. So we're going back into care homes now to keep an ongoing programme there. And the care homes have been very supportive, actually, of being in there. So we've got a central team that go in to do care homes, and that works really well. The homeless, I have to say, credit to the GPs who have been out in their populations. I've been out with 2 GP teams now vaccinating homeless people with them, and I have to say it's really humbling. But, you know, not only are they going out vaccinating, they're using that opportunity to do health checks and to, you know, really have sort of health conversations with some of this homeless population. So it was really lovely to go and do. But they have been linked in with the charities, the homeless charities, and we've been supported by them to go and vaccinate our homeless community. So we've done very well, actually, with the homeless, and we've been very supported with the charities supporting us to do it.
Thank you, Pippa.
Right. Lovely. Can I thank you, Pippa, for staying over the allotted time. That's really kind of you, and I think exceedingly helpful. But on behalf of the committee, can I also thank all of the other officers? Can I ask my committee to stay back just for about another 5 or 6 minutes? But can I say good evening to the officers? And thank you for your time, but more importantly, thank you for your input to this meeting.
No, and thank you all for your support.
Yeah.
Thanks. Bye.
Thank you so much. Yeah.
Thank you.
Thank you. Nice to see you all.
Nicola, can you tell me when all the officers have gone, please?
Yes, sure. I think we are still live on YouTube.
That's fine. Because apart from my any other business, which I suppose doesn't matter really if it goes live, because at least folks know that I'm trying, or very trying. So,
why not?
Members, thank you very much for your input to that. I think we've actually gained a lot more information than I thought we might. So that's good. Could I just say that because we've had to cut the time short to just over 90 minutes, to be fair, if you've got any other questions, if you could send them to the coordinators so that they could come back to me, and then we'll send like a package of questions off and get the answers as soon as we can back. And certainly we'll put a time limit on it by the 1st of May. The other thing we spoke about in our pre-meeting, of course, was the work plan going forward. And I think what has arisen very clearly from today's meeting, apart from the one that I highlighted, which was on our list overlapping anyway, which was hospital and clinic outpatient appointment transport, which I think is going to be a really big issue going forward as we ease out of the pandemic. But I think there are a number of issues in a work planning meeting that we can try and put forward a programme for obviously the last municipal year of the present administrations, whether we're all together or whether there's going to be replacement people on the year going forward. So what we need to do is to try and get a date. And I'm well aware of PERDA and people going door knocking to try and get their respective candidates elected to the London Assembly. That is very, very important. But I think if we can, it really would be important to do this work planning meeting, because there's much work for us or for whoever to do. So if we could do that, can I just get a steer from members that they're in agreement to that idea?
Yes, Chair, there's a lot of nodding and we're happy.
That's very good. The piece of any other business, as you know, whilst I've been in the chair, I've tried exceedingly hard without any joy whatsoever of trying to encourage Hillingdon to join our JOSC. Going forward, I think it's even more important that Hillingdon are a part of us, and that doesn't mean to say that we lose our co-opted member from Richmond, because I think that is equally as important as well. But I understand that there is change of leadership, and there's one or two other changes has been made quite recently on Hillingdon Council. And I wondered whether you felt that it would be a good idea for me, as your chair at the moment anyway, to write to Hillingdon and invite them to the new municipal year, starting from whenever we have that, or you have that first meeting, which hopefully will be sometime in June, because I think we need one in the new municipal year sooner rather than later. And I just wanted to get your steer on that idea.
Yes, Chair, I'd be very happy for you to do that. And colleagues are nodding, although most of them are on mute, but I'm taking it that they want to support your suggestion.
Right. So that was the couple of bits that I just wanted to talk to you about without the officers there. I don't mind whether we're still on YouTube. I think that's good to know that we're a healthy committee and wanting to do things going forward. That is my any other business. Can I do the honourable thing and ask members, do any of you have any other business before I draw this meeting to a conclusion?
I do, Chair, if I may, just very briefly. Please. Given that it's the last meeting of this municipal cycle, I wanted to, on behalf of the panel members and the people whom we represent, thank you very much for your chairing of this committee, how you've guided us through what is a very difficult year and extracted answers from attendance and answers from all of our representatives. You do an excellent job and we'd like to thank you for it. So thank you, Councillor Collins.
Thank you very much. That's very, very kind of you.
Thank you. Yeah, absolutely.
Thank you very much indeed.
Thank you so much.
That's really, really kind. Okay, so with that, very humbly, can I wish you all well in the future? Keep safe, and we'll speak again hopefully sometime in April.
Yeah. Thank you very much.